Welcome, everyone. I will get us started. Although I do see more folks joining, which is wonderful. I'll go over some housekeeping information first, and then we will kick off the content of the webinar. So I just want to direct people's attention to the chat and to the Q&A. That's what we'll be using throughout the webinar to capture people's questions. We are going to wait until all speakers have given their remarks, and then we'll turn to questions and answers. But I encourage you, as they occur to you, to plop them into the Q&A icon right there, and we will track those very carefully to make sure that we can offer those to the speakers. This webinar is being recorded. I imagine that popped up for you. We are going to archive this because there has been great interest in this topic. We will also post the speakers' PowerPoint slides along with that archive. So with that, I am going to kick us off by just offering some pretty broad overarching remarks, and then we will turn it to our speakers. I'm Maureen Hensley Quinn, Senior Director of Coverage, Cost, and Value at NASHP. We are very excited for this conversation. We know states are grappling with how to maintain access to care in rural areas, particularly and including supporting rural hospitals who are facing potential closures due to financing challenges. Medicare's Rural Emergency Hospital Designation, originally established through the Consolidated Appropriations Act of 2021, became effective on January 1, 2023. The new designation is intended to help rural hospitals at risk of financial failure by offering an additional monthly facility payment, however, also requiring certain changes to service delivery, including the elimination of inpatient care. To implement this new model, states need to take certain steps to provide hospitals with this option. Several states have already taken action to implement the REH designation. Joining this webinar, you will hear about the requirements of the new Medicare designation from the Centers for Medicare and Medicaid Services, known as CMS, as well as experiences in implementing the new designation in Kansas and in Michigan. There will be ample time for questions and answers. And as noted, just for those joining, I direct you to please share your Q&A within the Q&A box. We are tracking that carefully. So I am going to be very brief in my introduction of the speakers, recognizing that you can go to NASHP's webpage to see their full bios. But want to highlight that Kiana Banks, was a technical advisor at CMS, will kick us off. Jennifer Findley who is Vice President, Education and Special Projects at the Kansas Hospital Association. John Barnas, Executive Director of the Michigan Center for Rural Health, and I apologize if I got your last name wrong. Matthew Jordan, Manager of the Non-Long-Term Care State Licensing Section in the Michigan Department of Licensing and Regulatory Affairs, will round out our formal speakers, and then we will move to the Q&A. So with that, I am going to turn it over to Ms. Banks.
Thank you, Maureen, and good afternoon, everyone. CMS certainly appreciates this opportunity to present some information on this brand new provider type that has been established called Rural Emergency Hospitals. Next slide, please. I'm Kiana Banks. I am a technical advisor at the Centers for Medicare and Medicaid Services. I work with the group that establishes, maintains, updates the health and safety standards, also known as the conditions of participation for a host of Medicare and Medicaid participating providers and suppliers. Those include hospitals, critical access hospitals, ambulatory surgical centers, hospice, home health, and probably about 12 to 13 others. And now, of course, the newly established rural emergency hospitals. Next slide, please. So Maureen mentioned a little bit of the background, and just to touch on that a little bit, this brand new provider type was established by Congress in the Consolidated Appropriations Act of 2021, and it was enacted in December of 2020. And the aim was really to address the rural hospital and critical access hospital closures that were and have been taking place affecting rural communities. And it's been resulting in a lack of access to key services, including emergency care for the members of these rural communities. Next slide, please. So within the Consolidated Appropriations Act, there are some statutory requirements for this brand new provider type. So they must convert from either a rural hospital with not more than 50 beds, or they must convert from a critical access hospital. They must provide emergency services, and they must furnish observation care. And they can also provide other outpatient services as specified by the Secretary through rulemaking. And we touch on that in our final rule, and I'll touch on that a little bit later in the discussion. Next slide, please. So these providers may not exceed an annual per patient average length of stay of 24 hours. So there is a limit to the amount of time that patients can stay in these facilities, essentially over an average. They may not provide any acute inpatient services. So this is an outpatient provider only. So they cannot have any inpatients that are receiving services there as an inpatient. We often get a lot of questions whether or not rural hospitals or critical access hospitals that have swing beds could maintain those swing beds if they convert to a rural emergency hospital. Unfortunately, the answer is no, but fortunately, they are able to provide SNF level services if they have a distinct part skilled nursing facility unit. And what that means is it's a separately certified area of the facility that has to meet the skilled nursing facility requirements, and they're also paid based on the skilled nursing facility prospective payment system. So they are able to provide those needed long-term care services in the community as well. And they're eligible for payment as we speak as of January 1, 2023. We note that the statute does not prohibit an IHS hospital, that's an Indian Health Service hospital, or an Indian Health Service critical access hospital from converting to a rural emergency hospital. That's a question that we have received frequently. So we also try to usually highlight that, that those types of facilities would still be eligible to convert to a rural emergency hospital. They must be staffed at all times 24/7. The statute is silent on specifically the type of staff or who needs to staff the facility at all times. So we have some language in the final policy in the rule to address that. And what we have required is that the individual that's staffing the facility 24/7 needs to be someone who can communicate effectively to a provider or practitioner, what's going on with the patient, and they should be able to identify the need for life-saving measures such as CPR and be able to perform the CPR. By the statute, they must have a transfer agreement with a level 1 or level 2 trauma center, and they must have an action plan for initiating RH services. And the rural emergency hospital has the option to convert back to its prior designation as a critical access hospital or a rural hospital if it chooses to do so after becoming a rural emergency hospital. Next slide. So with the conditions of participation, again, also known as the health and safety standards, we finalized those policies in a final rule that was sort of within a payment rule. I've listed both of those here because it is a little bit confusing. So the payment rule, that final outpatient prospective payment system rule, also contained the final policies, not only for the conditions of participation for rural emergency hospitals, but also the final policies for payment for rural emergency hospitals and also for enrollment for rural emergency hospitals. Next slide. And we did a ton of research once we received word that this was a new provider type that was being established. And one of the things that we also did was we published a request for information, or an RFI, in an earlier payment rule back in August of 2021. We did receive some robust comments from stakeholders, stakeholder organizations on that RFI. and then we used that information to help inform our policymaking. We went forward and published a proposed rule back in July of 2022, received robust comments on that proposed rule as well, and then we went ahead and finalized the final rule in November of 2022. So we worked collaboratively within our agency, with our partners within the government, such as HRSA outside of our agency. We also had different calls and meetings with stakeholder organizations. We had several public-facing stakeholder calls. CMS has calls that are called open door forums, where providers themselves are able to call in and ask questions and state any issues or concerns that they might be having. And so we took advantage of those calls as well to help with our policy making. Next slide. So the conditions of participation for rural emergency hospitals are based on the statutory requirements, as they are for most other provider types that are participating in Medicare and Medicaid. We did closely mirror the rural emergency hospital conditions of participation after the critical access hospital conditions of participation. That's something that commenters noted, not only commenters on the request for information, but also in our proposed rules. So folks seem to be pleased with CMS's approach in doing that. We did mirror some of the rural emergency hospital conditions of participation after the hospital requirements, and as well as the ambulatory surgery center requirements, because ambulatory surgery centers are an outpatient only provider, just like rural emergency hospitals. Next slide. So the Consolidated Appropriations Act of 2021, again, has that set of statutory requirements. I talked about the fact that it must be staffed 24/7. The statute also notes that a practitioner needs to be available to furnish rural emergency hospital services 24 hours a day. The statute actually requires that the rural emergency hospital meet the critical access hospital requirements for emergency services. And what those requirements state is that a practitioner needs to be on call 24 hours a day and then present to the rural emergency hospital within 30 minutes of a patient arriving for services, or within 60 minutes if the facility is located in an area that's considered a frontier area. And again, that's something that's consistent with the critical access hospital requirements. So those critical access hospitals are familiar with this requirement. And again, the rural emergency hospitals must also meet the applicable critical access hospital staffing and staff responsibilities requirements under the critical access hospital COPs. And so we cross-reference those as well. And this is not an exhaustive list of the requirements. We just try to highlight some of the key points, and especially those that are sort of highlighted in the Consolidated Appropriations Act. Next slide, please. So again, they have to have this transfer agreement with the level 1 or level 2 trauma center. I talked about the emergency services requirements and the fact that they also have to meet the critical access hospital emergency services requirement. One thing to also note is that rural emergency hospitals are subject to the EMTALA requirements under 1867 of the Social Security Act as well. Next slide. So I've listed the requirements here that generally reflect the critical access hospital standards and staffing, medical records. You might see like some very minor differences, but for the most part, they're very consistent with the critical access hospital COPs. There are differences because these are two different provider types, and also we note that critical access hospitals are an inpatient provider. They are required to provide inpatient services, while rural emergency hospitals are an outpatient only provider, only providing outpatient services. And we have a standalone QAPI requirement. We have standalone infection control requirement, standalone discharge planning requirement. We do have, you will see some differences in how the conditions of participation are set up in some cases for rural emergency hospitals, because we have standalone conditions of participation, such as pharmacy services. That's something that is unique to rural emergency hospitals and hospitals, but critical access hospitals are set up a little bit different. We did that for several reasons. Again, this is a different provider type, and also to make it easier for providers to understand what the requirements are, to make it easier to assess compliance with the requirements and so forth. Next slide. And again, here's just a further list of some of the additional conditions of participation that you'll see. One of the things that I'd like to note, there are some differences in the laboratory services requirement. The critical access hospital requirements list out for their lab services requirement. They list out specific lab services that have to be provided by the facility. For rural emergency hospitals, we offered more flexibility and noted that they need to provide services that are consistent with current standards of practice in the provision of emergency services. So they have some flexibility in determining what their patient population needs, and also ensuring that those requirements are consistent with current clinical standards of care. There's also a patient's rights requirement for rural emergency hospital. And I just note that in the same rule, we did finalize a patient's rights requirement for critical access hospitals. And so now across critical access hospitals, rural emergency hospitals, and hospitals, there is a standalone patient's rights condition of participation. And the physical environment requirement for rural emergency hospitals was more closely modeled after the ambulatory surgical center requirements, because again, that's an outpatient only provider. So there's some differences that needed to be taken into consideration when you have an outpatient provider versus an inpatient provider for physical environment requirements. And next slide. And just to touch on those additional outpatient services, we listed within the final rule some services that would be appropriate for rural emergency hospitals to provide, especially given that they're providing care in these rural communities. We listed radiology, laboratory, outpatient rehab, surgical services, behavioral health services, and highlighted substance use disorder treatment, as well as maternal health services. So again, this is not an exhaustive list of services. The facility can provide additional outpatient services should they choose to, and they're not required to provide these lists of services either, but they're services that we felt were important enough and key enough to sort of highlight in the rule, to note that these community members in these rural areas would benefit from having these services. Rural emergency hospitals don't have to provide maternal health services. However, they can provide low-risk labor and delivery services that are supported by the necessary emergency surgical procedures. And we have some discussion about that specifically in the rule as well. I point that out given the challenges that are associated with the provision of maternal health in rural communities and the need for that service in those communities. And next slide. And that's all I had. I just wanted to give a high-level overview of some of the requirements and the approach that we took to developing the requirements. We do have some of my partners from CMS on the line who can speak to any specific questions you might have regarding things like payment or enforcement of the requirements. If you have any specific questions, you can contact myself, and that's my email is first. And then regarding eligibility enrollment in the conversion process, you can email the bottom email. And thank you. That's all I had.
Thank you so much. I believe we're going to move on to Jennifer. Again, thank you all for writing your questions and your comments into the Q&A or into the chat. We are collecting those and we will share them at the end. Jennifer, I'm going to hand it over to you.
Okay, thank you so much. I am with the Kansas Hospital Association, and I also work with our foundation, HealthWorks, here at KHA. And this is a project that we've been engaged in for quite some time. If you go to the next slide, not that I'm wanting to give you all a history lesson, but I had this up here just to show you that we've been doing work in this area since 2012. Our board challenged us to get ahead of some of the challenges that were happening in our state. So we formed a member-based group who did a lot of research and work and ultimately developed their own model. They called it the primary health center model, and it is almost identical to what we have today as a rural emergency hospital. So our journey is going to look a little bit different than most of you listening because we have been working on this for so long. If you go to the next slide, I'm going to show you what we did in a general process to help get folks prepared and especially our legislature ready to help us go down this journey. So we did, as I said, a lot of research, and we've built what we call the case for change and spent a number of years really trying to educate our hospitals, partner organizations across the state, our policymakers, and even the general public about all of the challenges facing Kansas That was important because it really created the framework and the urgency for the need to do something new and different. So by the time we got a new opportunity, which was the rural emergency hospital, our folks already understood the challenges and they were ready to embrace solutions that might be presenting us. On the next slide, I've talked about what some of the things are that we created in this case for change, or things that we wanted to talk about and educate others on. We looked at some of the big population shifts impacting the rural areas in our state. We talk about the uninsured rates, and the financial challenges facing our small rural hospitals. We talk about many of the workforce challenges, the low level of public health funding that our state has provided compared to other states, and then the overall decline in our health rankings over the last 30 years. Really to just kind of set the stage that we have a lot of challenges facing our rural healthcare system. And then we talk more specifically about some of the challenges facing rural hospitals. So we try to educate folks about how there has in our state really been this shift towards more of an outpatient service model versus inpatient. We have regionalized care across our state and done that for a number of years. So many of our small rural hospitals are operating almost identical to a rural emergency hospital, but they still have that requirement to maintain the inpatient beds. We talk a lot about the financial challenges facing our small rural hospitals. We try to educate folks about how the reimbursement process works for small hospitals, and especially our small prospective payment system hospitals, and the challenges that are very unique to them having low volumes and trying to make the current process work. We talk about some of the regulatory challenges too. So we build, again, this case to help folks recognize that we need to do something different. I mentioned that we spend a lot of time, and on the next slide, I'll show you, with partner organizations, because we thought it was really important that this not just be a message coming from hospitals, but it should be a message coming from anyone in our state that is concerned and passionate about rural Kansas. So we, of course, worked with a lot of the healthcare organizations in our state. We did numerous webinars and meetings with these kinds of groups over the couple of years leading up to our legislation being introduced, to help them understand the same kinds of challenges that we were identifying. So our medical society, the family physicians, public health organizations, long-term care organizations, EMS, mental health centers. We have a number of private health foundations across our state. We engaged all these folks in a lot of conversations as we were moving forward. We also tried to talk to our health insurance companies, both in Kansas, we have a Medicaid managed care program. So we were talking with our NCOs and making sure that they were aware of what things were happening and how we would need their assistance. And we also talked to our commercial payers. In Kansas, Blue Cross Blue Shield is our largest commercial provider. And so we certainly made sure that they were at the table and part of our conversations as we were moving through this process. We involved a lot of local government associations, the League of Kansas Municipalities and the Kansas Association of Counties, because in Kansas, many of our small rural hospitals are governmental related. They're either city or county hospitals. And so we're going to need the engagement of those local elected officials in order for a change to happen. And then I mentioned other groups interested in rural issues. Here in Kansas, the Farm Bureau became a very passionate partner of ours and really helped us by spreading the word, inviting us to speak in a number of their conferences so that we could get the word out to the general public. We've worked with our extension service, the Bankers Association, several education groups, and AARP are just some of the other interested groups that we made sure we had at the table and were part of our discussions. And then, of course, we included elected officials at the governor's office and others from the state and federal level. So I'm going to tell you on the next slide a little bit about what we did. So we introduced a bill in January of 2021. We acted very quickly right after the Consolidated Appropriations Act was passed. But again, a lot of that was just a benefit of the prior work that we had done in this area. So what we tried to do is look at our current statutory language. We looked at the critical access hospital statutes as a starting point. We created the way that our state operates. We have licensure categories for hospitals. So we have a general hospital, a critical access hospital, and now we have a rural emergency hospital. So we created that new licensure type, mirroring most of the language that was in the Consolidated Appropriations Act. We then went into the other parts of our statutes that referred to types of hospitals and inserted the word REH after where it would list the kinds of hospitals, we made sure that rural emergency hospital was listed there. We did not, in our legislation, attempt to dictate any kinds of specific payment details. We did guarantee the individuals who were served at a rural emergency hospital that current insurance plans would accept it, but that's pretty much where we stopped. We let negotiation happen then between the payer and the hospital and didn't try to put any kinds of specifics into the process. So this bill, we actually introduced two bills, one on the House side, one on the Senate side, because we have a pretty short legislative session. We wanted to make sure that at least one of them got through the process. So we worked through that process, had some hearings. Many of those partners that I showed you on that earlier slide participated in hearings, offered testimony and support. We really had a pretty smooth process through. We had some questions, no major fights. So we were able to get our bill through the 2021 session, and it was signed by the governor in May of 2021. If you, on the next slide, some of the key talking points that we used as we were moving through this process, specifically with our legislature, was really trying to remind them of all of the struggles that were happening with our hospitals, and that this was just one opportunity to make sure that we could preserve access to care in our rural areas, and really tried to keep the focus on that, not so much about how things were changing or some of the other challenges facing our hospitals, but really that we wanted to preserve access. We also talked about this is not a requirement. It's just another tool in the toolbox for communities that might be looking for an option. I think it's really important to hit on that one, because oftentimes people think that this is something that they're going to be forced into, and we made it very clear that we would not be forcing any hospitals in our state to make this conversion. It helped us to be able to talk about how this really was a solution based in the work that we had been doing since 2012. So folks felt pretty comfortable with it. And then this idea of really not prescribing any kind of payment rates really did help keep the insurance companies and others at the table. It really did reduce, I think, a lot of potential conflict that could have happened by not dictating any kind of payment structures. One of the other things that, as a background to this process, is that Kansas is one of the few states that has not expanded Medicaid. So for our legislature, this was an easy thing for them to say that they were doing something to assist hospitals without having to actually take that vote. So I do think that worked in our favor in getting this particular piece of legislation through the process fairly quickly. We still have some activities going on, and that's on the next slide. We're working right now on state rules and regulations. So even though we have the licensure law and have had that, we were waiting for CMS to release their final rules before our state promulgated then their rules and regs. So technically, right now we cannot license any REHs, but that process is moving quickly, and we hope in the next couple of months we'll be there. We also learned, this was a lesson learned, so something I would encourage states to look at is we do have a Medicaid provider assessment program in our state, and because of the way that it was written, there was no specific exclusion for rural emergency hospitals having to pay the tax. The way that our program is set up right now, critical access hospitals don't have to pay the assessment, but they reap the benefits from the program. It was certainly not our intention that rural emergency hospitals would ever have to pay that assessment, but it wasn't written in there. So we actually just finished last week getting an amendment to that program through the legislature, but that might be something to look at if your state does have a provider assessment program, to understand how REHs fit into it, and would certainly be smoother, excuse me, to address that up front. We're currently looking at the necessary provider issue that has arisen. I saw a couple of questions, and so I'm just going to say we're working on that one to get some clarity and to make sure that our hospitals understand what that means. I know we'll probably talk about that in a minute. And then we're actively working with several other organizations on a rural emergency hospital 2.0 bill at the federal level that would address some of the technical changes that have been identified to fix this model. And then I just included here on the next slide, just I think in order to help folks conceptualize what this model means and how it works, you need to have some pretty easy graphics. So this is just a sample of some of the things that we've used. This is just a little picture diagram that we've used in many of our presentations to really explain where a rural emergency hospital sits in the continuum. And then on the next slide, just a quick, easy way of explaining the services that are required and optional so that, again, folks have a general concept of what this looks like moving forward. So that's all I have. We do have some additional information out on our website. I'm always happy to answer questions or provide additional information if that would be helpful.
Thank you so much for that excellent presentation. We really appreciate that. Now, I'm just going to thank everybody again for your continued comments, chats, questions. We are collecting those. But I am going to turn it to John in Michigan to continue the conversation. And then we'll also hear from Matthew, then we'll open it up. John, to you.
Great, thanks, Maureen. Jennifer, that was very handy, the last couple slides. I think I'll steal those and use them in Michigan. I'm just gonna kind of tee this up for Matt. So as Kiana mentioned, and we all know, the REH legislation was enacted in late December of 2019. I think I first noticed it probably came from an FRHP bulletin, and it's like, well, looky here, a new designation. And I go back to when Flex started too. So I sent it to our friends over at the Department of Licensing and Regulatory Affairs Agency, in particular to Larry. Said, look at this, Larry. And he said, oh, I didn't see this. So can you kind of bird dog this as it's moving through? Instead of, well, of course. So at some point in time, we also, as this legislation became more widely known, we have a hospital in Michigan that back in probably February, March, said, we're pretty interested in this. So we had a little emphasis on our part to make sure that this was going to, get to the finish line. Because we also, at some point in time in 2020, read where CMS was requesting that states have their application ready for hospitals to submit on January 1st, 2023. So these things take time, right? It's because you're going to have state agencies involved, associations, organizations. So we had our first meeting in January of 2021 with LARA, as we call them, the Center for Rural Health, us, and the Michigan Health and Hospital Association, MHA. And as we continue to meet on a monthly basis, we continue to add partners in this trip of finishing up an application. So we added Medicaid, the Michigan Medicaid Agency. We added public health, certificate of need. Michigan's a certificate of need state. The state EMS agency, that was crucial to also add. And so as we continue to move forward, Matt and his team were developing the language in the application. And at the end, by November, the MHA had found a couple sponsors, one on the House side, one on the Senate side for the legislation. And then in a lame duck session in December, our governor signed the legislation. And so we were able to get across the finish line and be in compliance with the January 1st, 2023 date. So it took time, some effort. We had great partners, especially with the Hospital Association and with LARA and across the state with all the other agencies too. So that was kind of our process. It was time, took a lot of time, worth it, because we have one hospital that will be using it now, and we have 2 in the parking lot kicking the tires. So we figured when this started, we would have 3 to 5. Well, we're at 3. We'll see if we get to 5 in the next couple of years. Having said that, Matt, you're the guy who can work the magic. You take over, please.
Thanks, everyone, and thanks, John and Jennifer as well, because you both of you guys teed it up for me, because I saw a lot of parallels to what we did, to what Kansas did. John did a good job of outlining exactly where we're at, and so I get to deal with the nuts and bolts of the implementation. But as John had mentioned, Michigan is a certificate of need state, which, those that don't know, determines how many available beds are in certain space, in certain areas, certain counties, certain regions. And so that presented an initial problem that we had at first. And what we did we did a lot of actions similar to what Jennifer described for Kansas, but we did a lot of things differently. Initially, when we were looking at this, we were thinking of, oh, let's create an REH designation specifically on the license. And Michigan has never been a state where we've had, or at least has not for the last 3+ decades, been a state where we've had hospital types specifically identified. We literally have 2 hospital license types, and they're 2 separate ones. We have psychiatric hospitals, and then we have acute care, traditional straight up hospitals. What we did have was language that already existed and has for a couple of years, or maybe even a few decades, was language that allowed a existing hospital in Michigan that had beds that were designated and given it to them from certificate of need to come forward and reduce their bed levels to the numbers that they wanted to in order to become and make the claim that they're a critical access hospital or CAH hospital. So when we were struggling with this, do we create a new license type? Do we come up with an RAH license type or other things? We had a lot of people that had input in there, a lot of agencies. We were really struggling on how do we change the law? How do we change the language in order to have an REH license or designation? And what we did was we took a look back at it and looked at our process for becoming a CAH hospital. And we basically mirrored the same language in statute. John described how that language eventually got through and we were able to change the statute. But essentially we took what we had in Michigan, which was in the past, if a hospital came forward and said, they want to achieve to a certain CAH level, usually it's driven by their total bed count number. We had statute in there that would let them reduce their beds not by more than 50%. And they could hold that for up to 5 years. It was very similar to some federal language, very similar to other things, but essentially they retain a license as a hospital. And they said at one point we had 50 beds and now we have 25 beds, and they go to then the required agencies, whether it's Medicaid, CMS, whomever, and make the claim that says we are a CAH hospital. We did very similar language, and that's what John described as the language that we got through, to do the same thing for an REH. A hospital can come forward and with our new language, make a presentation. They apply to us and they reduce their beds 100%. So they maintain a license. And say that they had 50 beds beforehand, they apply to us. We've simplified our application process, a simple 3-4 page application to us, and they said, on this date I'm hospital A with 50 beds, and starting on May 1st, June 1st, or whatever, we're going to seek and move forward for REH status. We're applying to have all 50 of our beds, all 100% of our beds temporarily delicensed. And so what happens is they maintain their existing hospital license. And again, we don't have it's just a hospital license. We don't make a designation calling them a CAH or an REH. But we execute that will show they have 50 beds before. They now have 50 beds temporarily delicensed. In essence, they are now a 0-bed hospital. And that allows them to take that license forward to that designation that's been executed on our license to whomever they need to make the claim to the feds, to Medicaid, to whoever that says, we'd like to finish this process and become an REH designated hospital. That was sort of the barriers that came from CMS. I'm sorry, from CON, Certificate of Need, because in Michigan, everything that designates you as a licensed hospital begins with beds granting. So they retain those beds. They just have overtly stated that they're all 100%, if they're in REH status, are now temporarily delicensed. They essentially enter into an agreement that they're not going to use those beds going forward for whatever designated time, up to the 5 years, and then they could do the renewal. So we mirrored some of the federal language there that allows them to continue or do that. And if they ever came back and said, we want to lose our REH status, return to just a licensed hospital in Michigan running 1, 2, 3, or all 50 of our beds, they can come back and apply at a date forward chosen that they want to, and then, you know, drop off the REH status. Again, the onus will be on them in terms of the terms and agreements that they would have to follow with the feds or whoever else is, you know, allowing them to be in REH status. But the process has been simplified for them to, you know, apply, temporarily delicense those in the state. Still maintains a license. It shows what they had, shows what they're currently operating at. There's a few things in our application, you know, for instance, the number and location of the specified beds to be delicensed, the time period, alternative use for the space, you know, that helps us and our health facilities engineering team, you know, understand that hospital A used to have 50 beds. They're now using the space for X, Y, and Z, or they're not using the space, so that we know that they're not, you know, continually maintaining and seeing overnight patients or doing anything that might, you know, be outside of the REH operating space. So pretty straightforward, but it took us a little while to get there. It took a lot of good partnerships with MHA, with John and the rural health team, and with Crystal and everyone to kind of get everybody on board with the what turns out to be a very, you know, simple and straightforward concept that is very similar to what we have used for critical access hospitals. But it was a new concept, and it was at first presented a lot of questions and barriers as how do we do that? And, you know, keeping it simple was the key to our success here. So with that, I don't have anything more. I'll turn it back to Sam and Maureen.
Thank you very much. That I really appreciate you all in Michigan walking through how you envision this to work from this state perspective. And I will share, surprising no one, we have a lot of questions from the group about conversion back and forth from a critical access hospital to a rural emergency hospital. And so I'm going to pose this one first, and then sort of there's some that cascade from it. So if a critical access hospital designates itself and converts to an REH, assuming that that happens successfully, and then the REH wants to convert back to a critical access hospital, is that considered a new conversion? And if so, does that hospital start the process from scratch? And again, building off of what Michigan just shared, I'm going to pose this to CMS, and then state folks can jump in with any clarification from the state level. But with that, I'm going to turn it, I think, to Kiana and your team first.
Yeah, thanks, Maureen. I am going to see if my colleagues can answer this one. Jennifer, are you able to take this question?
Yes, thanks, Kiana. The REH may convert back to a Cal Rural Hospital at any time. We don't have any time frame or limitations on that. They would be considered at that time, though, an initial enrollment for that elected provider. So for a critical access hospital or a rural hospital, they would be submitting an initial enrollment application. They would have to be determined to meet the conditions of participation. For cause, they would also be expected to meet any distance and mileage requirements at that time as well.
Does anyone else want to weigh in on that question?
Hey, this is Jennifer. So in Kansas, we have a number of critical access hospitals that are necessary providers, meaning they could not specifically meet the mileage requirement. And so this is an issue that is really important to us. We believe it will be a barrier, unfortunately, to many hospitals looking at this model, simply because everybody always wants to have that magic safety net waiting in their back pocket. So it's one that we are paying really close attention to.
Yes, and you're right in that fact that, you know, CAUs that convert to a rural necessary provider CAUs that convert to a rural emergency hospital will not maintain their necessary provider designation if they choose to convert back to a CAU. And as such, as we stated, would have to meet any distance and mileage requirements at that time of their initial enrollment application returning back to a CA.
This is Matt from Michigan. One of the things that I should probably point out, and it's not driven because we're a certificate of need state, but we are sort of a bifurcated or separate state. The actions that we take at licensing and regulatory affairs, or LARA, as John described it, are specifically around the four-walled hospital, the license that goes with that. We have a separate agency, the Michigan Department of Health and Human Services, others that are going to handle CMS, the setup for, designating them as an REH or a CAH hospital. But what our system allows them to do is they are an existing hospital. At one point, they may have had 5, 10, 50 beds. They make the changes to the license to match what they want to do going forward. So whether they are already a CAH hospital, that they may have had 50 beds, and now they're only operating at 25 beds, and then they want to then make the claim that they want to be an REH and drop down to 0. We take the license action that gives them they meet our terms, which are generally around operational and some of the other things, describing and limiting the space, making sure that they're not doing overnights, but then they make the claim back to the required agencies, whether it's at the state or federal level, that says we are now, based off of our license status, we now want to be an REH, or we want to return back to a CAH, or we were at CAH and we're becoming REH, or we're just going back to a regular acute care hospital operating all beds with no designation on them.
Okay, great. Thank you. Is there a financial limit of how much a rural hospital can currently make to be or not to be allowed to convert? And I'm going to take, because it doesn't say convert from what, REH or CA, I'm going to go ahead and take moderator's prerogative and say, is there a financial limit for a rural hospital that is currently a critical access hospital that wants to move to REH? Is there any financial limitations to that?
Hi, this is Kiana Banks. I don't believe that there are, but I'll just have our payment subject matter expert, Emily, just confirm that that's the case. Emily?
Yes, thanks, Kiana. That's right.
Okay.
And then while I have you, if a hospital has been designated an REH, is there any sort of financial limit to converting from REH back to CAH?
Yeah, I don't believe so. Emily, is that accurate?
Yeah, that's right. I'm not aware of anything.
Okay.
Great, thank you.
Maureen, I'm not sure exactly what financial limit, what the definition of that would be, but I would certainly hope that any community with a hospital that's looking to convert to REH, does their pro forma to make sure they look out at least 3 years and see if the payment mechanism that REH provides will allow for that facility to remain open, and vice versa.
So there are some questions, I'm going to say, about the interest level in hospitals in both Michigan and Kansas. And I will also share, just for the record, there was a comment in the chat that highlighted that while this is a welcome tool, so far in their state, there isn't a lot of interest coming from rural hospitals to change their designation. A note about loss of swing beds, loss of services, loss of allowable cost, recognizing that this is a substantial change and one that no hospital would consider lightly. And I don't think anyone here is suggesting they would, but is there any idea in Kansas and in Michigan about the interest level in rural hospitals to consider this change?
So I'm happy to take this one first. If you look at a couple of studies that have been recently released, Kansas is at the top of the list as far as the number of hospitals that might be a good fit for this model. So There's certainly been a lot of attention given to that. I can tell you that we have 2 hospitals actively pursuing designation right now, just waiting for our rules and regs to be finished. We have a couple others that are giving it some consideration. Of the 2, one's a critical access hospital and one is a PPS hospital. If you're not familiar with that, those are designations and payment structures under CMS. I would say our small PPS hospitals are certainly the most viable candidates. It's the easiest for us to analyze from a payment structure what this would really mean for them. Overall, I would just tell folks that Kansas has 123 hospitals. Of those, 82 are critical access hospitals. So we have the 2nd largest number of critical access hospitals in the country. Many of them are very small facilities. 40-ish of them have an average daily census of 2 or less. So I said this model is very similar to the way that they're operating today. It's just figuring out for the critical access hospitals the financial side of it and whether that really works. I think one of our biggest concerns is for those critical access hospitals, swing beds are extremely important to their communities. And we recognize that they could operate a separate, distinct SNF, but we're not sure if they have enough volume to make that financial model work. So that's one of the pieces that we're currently working on to help them in that analysis piece.
Yeah, just to piggyback on what Jennifer said, you know, we looked at a couple. So Crystal and I took a peek at who we thought would be thinking about or maybe moving into the REH world and came up with a list of like 7 or 8 hospitals, PPS and CAH. And right now, as I mentioned, we have one who is, you know, in process, and that's a PPS hospital, and they've been stressed to the max for a number of years. And that's true across the nation, right? So the PPS hospitals are usually in a weaker financial position than CAH. We have another one who I mentioned is thinking about it. They're also a PPS. A third is a CAH. And then there's probably 3 or 4 others that I think will eventually come around and want to discuss it, but they're part of systems, except for one. And one is a independent CAH whose CEO said, I would never give up my swing beds because my community wants them. So that will stop them from moving forward. So yeah, we probably, to answer the person's question, we know we have 3. We'll probably end up with 5, 6, or 7, within the next couple of years.
And so,
I'm sorry.
Yeah. So if we end up with 5, 6, or 7, that's going to be under 5% in the state. State of Michigan's got 10 million residents, 160 licensed acute care hospitals. Now, a good majority, half the population and majority of those hospitals are in 3 or 4 counties in the Southeast near Metro Detroit. Otherwise, the state is a very large state with 2 peninsulas. I think it's the 2nd largest state east of the Mississippi. And so, it's going to be a valuable tool for, as you get out into the state and get into the Upper Peninsula, you see much smaller hospitals that probably make up the majority of them. We have some very huge hospitals, but the majority of the hospitals in the state are these smaller level ones. I think John and Crystal know better, what the overall mix is on it, but that's the numbers that we're seeing.
And I'm going to direct this one to Jennifer, but welcome others to comment. This question is related to tips for engaging hospital leaders who may be hesitant to consider an REH status. How would you describe some of the key benefits to the communities that they serve, really focusing in on what this means for patient care?
Sure. So again, making this kind of case for change and asking folks to examine their internal operations, I think is one good step. The more you can talk about it in a general sense with the public, the more easy It will be for a CEO who is a little hesitant to introduce this idea to their board. We did a lot of board education at state events that we had also to make sure that they were keeping pace with these changes. We also have a special project in our state that our foundation is working with 2 of the private health foundations to create community conversations, is what we're calling them. But we will come in and help facilitate conversations in a community that wants to talk about the challenges facing them in the future. And then we can dive into specific options, the rural emergency hospital being one. We just completed this process. Now twice, had 2 community conversations in the one community that is actively pursuing REH designation right now. And for a lot of them, it was dispelling a lot of myths. Just making sure they truly understand what would stay and what would change. And for this particular community, a small PPS hospital, their average daily census was about 4. So we were talking about 4 patients a day that might have to go somewhere else for services because of their financial condition. They just shut down OB services. So their community is already starting to see the loss of some services. So for them, it was, how do we preserve access to those emergency services and outpatient services, and then just clarifying the rules. So I have a great presentation that kind of distills that down to the public consumption level. If folks would like to see it, I'd be happy to share it. And one just tip as you're talking about this, because I fell into this trap early on, we quit calling it overnight stays, and now we're calling it limited stays because of that annual average of 24 hours. We had a lot of people who truly thought they were going to be kicked out at midnight because they weren't allowed to stay overnight. So just a tip in the messaging side of things, that overnight word gets you in trouble.
Thank you so much.
I really don't have anything to add to what Jennifer said, Maureen. I think she covered all of the bullets that, you know, if I were to go back into a community and discuss with, you know, at a focus group or a town hall meeting, that's everything I'd have on my PowerPoint.
Okay, fantastic. I'm scanning one other question. I know we're running low on time, but one other question that I think others may kick themselves for not asking, and recognizing that some CAHs or PPS hospitals are owned by systems. What if the critical access hospital has employed primary care or employed specialists, urgent care off campuses? Would outpatient services in this sort of realm be permissible in REH model?
I'm not sure I fully understand the question. Are they asking if they're part of a health system already? Would those employees then be able to work at the REH?
It's unclear if the question is being asked about sort of, for instance, a hospital that is owned. I'm going to assume it's not, but they have employed physicians for outpatient services. So would those outpatient services and employed primary care and specialists be able to continue with the REH designation? And I see Matthew, you have a hand.
I don't know if this answers the question, but maybe this is where they're going with it. From our standpoint in Michigan, 2 things. One is anybody coming forward is initially licensed as a hospital. They have minimum standard requirements to meet, which includes staffing, policies and procedures, and operational effects like that. If you become a CAH or if you become an REH, your license doesn't change. You're still a licensed hospital, so you're still going to meet our minimum administrative rules. Now, what you won't have in there, and our rules don't really touch on this, would be things that say disappear, particularly with the REH language. You no longer have 24-hour stay, but we don't necessarily mention that as well. What we say is you have to have minimum staff, these, this nurse, this doctor, this director in charge. And also you need to have patient records, documentation, other things that go with that. That doesn't necessarily change. The other thing is we license the 4 walls of the hospital at 123 Main Street. If the hospital is part of a system and they have another hospital across the street, down across the county in another part of the state, that's a separate license and it operates separately on that. Conversely, though, we do recognize, well, actually, we don't recognize, but we know that CMS will say, hey, the hospital at 123 is financially or affiliated with this urgent care, this doctor's office, this freestanding surgical place that is not attached to the hospital. Those are either non-licensed or they're separately licensed, but from a reimbursement, CCN number, CMS, whatever connectivity, they may have some connectivity. We limit our space still at the REH is at 123 Main Street, had 50 beds, now has 0 because the 50 are temporarily delicensed, which are still licensed as a hospital. You still, must meet the minimum requirements. Now, if you're pulling staff from other entities, as long as they meet the requirements for the staffing, the operational and procedures, we wouldn't have a limitation on that. But I can only speak to what we do as a licensing agency for the hospital.
I appreciate that. And I do think the question, again, trying to be short and sweet, trying to give us some information to answer it, but appreciate the answer is, I just appreciate Michigan's answer. It may boil down to the licensing of that hospital and who is employed or operates out of it. And we may need more information to provide a more in-depth answer to it. But I just want to recognize the time we've gone over. I know we didn't get to answer everybody's questions. We will collect those questions, compile them, share them with our speakers and see if we can get some answers. If we can, we will post those answers along with the recording of this webinar, the slides, and we will make sure to include the transcript that is capturing this conversation all online. I just want to thank our speakers so much for such a wonderful in-depth discussion. And I know we've just hit sort of the tip of the iceberg, but really appreciate your time, your expertise. Thank you so much. And thank you all for participating. Goodbye, everyone.